Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launch of a joint NAMS-AIIMS PGIMER Navigate CME program for postgraduate students in all the AIIMS and other eminent institutions of the country. Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on the first and third Friday of every month from 3 p.m. to 5 p.m. The CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medical CME is to help them to be more proficient in their profession. Thank you for your kind support.
Good afternoon and a very warm welcome to our respected dignitaries, esteemed NAMS faculty and all the attendees joining yet another session of an insightful topic, Evolution of Eye Bank and Eye Donation by the National Academy of Medical Sciences, AIIMS, PGIMER, Navigate Online CME Program. I am Dr. Ritu Singh and I have the pleasure of moderating today's session, and I would like to next request Dr. Ajay Kumar Sood, sir, for the opening remark. Over to you, sir.
Thank you, Dr. Ritu. On behalf of the National Academy of Medical Sciences, it is indeed my great privilege and pleasure to welcome the distinguished speaker for this afternoon, Major General J.K.S. Pariyar, sir. Welcome, sir. And sir is our senior council member also. And it is really a great privilege that you had kindly agreed to coordinate this series on ophthalmology. Today, we are having the last session on this. And the topic which sir is covering is of great interest to all of us, not only to the ophthalmology student, that is on eye donation and eye bank. So it's a very important topic. And I'm sure that the practical tips which we learn from Major General J.K.S. Pariyar sir will be useful to all of us, especially to our PG student. I also extend a warm welcome to Dr. Ritu Singh, who has just joined for the first time for this program as a moderator, and we look forward for your support in future also. I also take this opportunity to extend a warm welcome to all the faculty members, participants, and the PG students who are attached with us in this program. And I think especially for the PG student, it is a very good opportunity. If you have any questions or any remarks for the faculty members, if you can want to add some remarks, please put your question and remarks in the chat box. General Pariyar will be happy to answer those questions at the end. So once again, I extend a warm welcome to all of you. And now over to you, Dr. Ritu, for further proceeding. Thank you.
Thank you so much. It was very kind and generous of you, sir. Moving ahead, I would like to request Mr. Raviji to play a short message from our President NAMS and Director AIIMS.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and Allied Sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Namaskar. At the outset, I congratulate the team behind the NAMS-AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
With heartfelt gratitude, I extend a big thank you to Dr. Digambar Behra sir, President NAMS, and Professor Dr. M. Srinivasa, Director AIIMS, for their short messages. And indeed, this session is not only insightful for postgraduate students, but also young faculty members. Without much further ado, let's dive into the topic that is evolution of eye bank and eye donation, which is going to be presented by someone who needs no other introduction. We have with us retired Major General Dr. J.K.S. Parihar sir, who is presently the Professor of Ophthalmology and Head Academics and Training at Center for Sight, New Delhi. He has served as former additional DGFMS at Medical Research Health and Training and is chairing multiple professional societies. Sir has an immense teaching experience of over 34 years and has been professor for 20 years heading education at Armed Forces Medical Services. He has more than 125 articles, 5 books, and 25 chapters to his feather cap. Sir is a researcher with extramural and intramural commitments and innovation in color vision detection devices and ICEL, and has also filed a patent for the same. Not just this, Sir is also a member of 33 national, state, and regional ophthalmic professional societies. He's a recipient of multiple awards, some notable such as Sena Medal, commendations of COOS, VCOS, GOC, Distinguished Service Award by Asia Pacific Academy of Ophthalmology, FAMS and Dr. S.D. Sharma Oration Award, and also Air Marshal M.S. Boprai Oration Award. Nonetheless, he's also a recipient of Limca Book of World Records for performing phaco-cataract surgery at the highest altitude in whole world. Sir holds special interests in femtolasic and glaucoma, keratorefractive surgery, ocular trauma, and community ophthalmology. Thank you so much, sir, for gracing us today, and over to you without wasting much time. Thank you again.
Thank you, Dr. Ritu, for giving such kind introduction. And I am equally grateful to Professor Sood for his words and constant support, encouragement. To Dr. Kapil, Dr. Sareen, who has been the president and present president, all the staff of the National Academy. Sir, there is a problem with my laptop internet connection. It is quite unstable. So I have switched over to the mobile. Now, I would request you to kindly share the slides that I have already submitted to you. Full screen, sir. Thank you very much. Next slide, please. Welcome to all my beloved PGs and younger faculties on this topic of corneal blindness, eye banking. It's a very interesting and important topic for PGs as well as for the community ophthalmology commitments, what all ophthalmologists, irrespective of their contribution as a cornea specialist or retina specialist or cataract surgeon, we all are responsible to take care of this national program. These figures are estimated figures. It's very because in our such a vast country, exact data registry is not possible. These are based on the different surveys what has been carried out by central agencies, All India Institute of Medical Sciences and ICMR regional ophthalmic societies. More than 12.7 million people are globally suffering from the corneal blindness. And corneal blindness is one of the world's leading cause of the avoidable blindness. Most who are corneal blind live in a low and middle income countries where the conditions goes beyond not being able to see. Next, please. Next slide, please. This is a world map showing leading indications for corneal transplant reported by almost 100 countries. And if you go by this map, the Western world is having the predominance of the conditions which are the Fuchs dystrophies and keratoconus. Whereas in the Asian countries, you find that the infectious keratitis and injuries, they contribute more. And the another, which is coming in the developed countries, which is related with the bullous keratopathy, means corneal decompensation due to any kind of intraocular surgeries. Next, please. National Society for Prevention of Blindness in India. India was the first country in the world to launch the national program for control of blindness in 1976 with the goal of reducing blindness prevalence to the 0.3% by the year 2020. With this, in continuation, in 1999, WHO launched the Vision 2020 program, the Right to Sight, a joint endeavor with the IAPB to eliminate avoidable blindness by 2020. However, we could not achieve this target because of multiple reasons, the administrative, logistic reasons, and various other supports which is required for the financial in the different countries. But we are definitely inching towards eliminate avoidable blindness in next decade or so. The significant evidence on the magnitude of blindness and thorough large population based surveys have been carried out. Next, please. These are the figures based on the various surveys, and the corneal opacity, it amounts to be the 8.2% of the cases. Among the major causes of blindness in population aged above more than 50 years, where the cataract is the most common. Then it is the corneal opacities, and most of them were associated with the infective elements and trachoma. Cataract complications, again, it was next to the corneal opacities, and that leads to the one of them is, other than the posterior capsular opacification, is a corneal decompensatory changes. If you go by the below age 50 years, again the cataract continues as a major cause. But if you go in the younger age groups, then you find that the corneal opacities 0 to 49, in this group it is one of the leading cause of the blindness. So in the productive age and the pediatric age group, the corneal blindness is one of the most common cause of the preventable blindness. Next, please. It is estimated that around 11 million people are there with the having the visual acuity less than 660 amongst the corneal blind, and almost 2.5 million, one-fourth of it, are having the bilateral corneal blind. Those definitely need treatment, and at least 10% of them can be benefited by the corneal transplant. The different studies like the RAB study of 2007 has put that the corneal blindness contributes to the 1% of total blindness, but it may be varying. It may be around 3 to 5% region wise. In certain places in the zone it is more, in some zones it may be less. Out of which the majority are children, as I mentioned earlier, and every year at least 50,000 new bilateral corneal blinds are added to the already having the prevalence and the backlog. Next, please. In our country, the common causes of corneal blindness, the infectious lesions, fungal corneal ulcers, bacterial, they are the most common cause. The injuries is the second, and followed by the complications following the eye surgery and the Fuchs endothelial dystrophies, other dystrophies, keratoconus. It goes lower in the prevalence and incidence in our country and any developing country as compared to the Western world. Next, please. If we go by that how can we cope up with this problem? So roughly around 11 million death occurs every year in India. And out of this 11 million, at least 3 millions can be considered for the as a target for the getting the cornea. Whereas we are able to get around 55 to 60,000 eyes per year. That exact figure, again, it is not available. It is the figure which is the data which has come to the Eye Bank Association of India and the Government of India. And number of corneal transplant is around 35,000. So considering the backlog, we need to have more corneas, and target is to have at least 1 lakh corneal transplant if we perform by 2030, then the entire backlog can go away. Next, please. What are the problems with the eye donations? There are certain taboos. The religions, particularly in the North India, the Hindu religions myth is there of the Angbhan. If somebody is going to the heaven without any specific ang, whether it is eyes or so, it is presumed that in the next birth he will be blind. So that is the reason the donations becomes quite compromised in the North India and certain Hindu domain areas. Lack of awareness is another reason. Fear of disfigurement. That is that if somebody has taken our eyes, then the dead body will have the disfigured figure. Apathy and forgetfulness. Lack of favorable legislations. Though the government of India has worked on it and so many amendments have been carried out in legislation, but still there are so many lacunas are there which needs to be strengthened. Next, please. Who all can be potential donor? The people of any age. There is no restriction so far the age is concerned. Earlier it used to be that the extremes of the age, the very young child or the very elderly. But now we are not using in all cases the complete cornea. In certain cases we may use the part of the cornea like the anterior surface for the anterior corneal opacities and the posterior endothelium for the endothelial diseases. So now our requirement is to have a good transparent healthy cornea which has a reasonably good above average endothelial cell count. Spectacle users, no restriction on it. After all, we are taking the cornea, and after surgery, the refraction will be much different than what the deceased whose body from where we have harvested cornea had a refractive error. Eye surgery patients, if anybody has undergone cataract surgery, glaucoma surgery, or the retinal surgery, their corneas can be considered for suitable if there is transparent and the corneal endothelial cell count is adequate. In the same manner, the diabetes and hypertensive, they can also donate the cornea. So there are a lot of myths about the donations, and we find that almost every person can donate the cornea after their demise, except in a very few, that is very limited number. Next, please. Next, please. Yeah. Actually, this slide has gone little faster. Just one back trip. Yeah. No, reverse. Yeah. Thank you. Yeah, going little. Just one. No, you are going forward. I want reverse because there is one slide is missing. Reverse, please, reverse. Yeah, this is all right. So contraindications are basically, yeah, please continue with the previous slide. The contraindications are basically local contraindications where you have any disease which is affecting the paranasal sinuses or the orbit, and particularly the fulminating viral, bacterial and fungal infections, whether they are in the orbit and address area or the systemic involvement is there. Rabies, any viral infections, rabies, hepatitis B, C, HIV, COVID, these are the contraindications because there is a risk of transmission of disease through tears and the cornea, hemopoietic disorders, local malignancies involving orbit, paranasal sinuses, adnexa, and death due to the unknown causes. A patient, those who are on the very long period, they are on the ventilators, are also considered for the relative contraindications for using the cornea for transplant purpose. But these are not the contraindications for the donation, because the cornea, those cannot be used for the optical purpose or for the corneal transplant, are definitely, they are not thrown as a waste, but it is used for the training purpose, research, and other activities. Next, please. And another myth is there that the corneal removal may take a lot of time. It does not take much time. Removal of eyes hardly 20 minutes, and it does not give any disfigurement. There is hardly any delay in the funeral arrangements. Next, please. This is a rough period which has been marked as a 6 to 8 hours of the time from the death time. Idea was basically that by, yeah. Now, within 6 to 8 hours is the period where we expect that by that time the corneal endothelium will remain viable in the tropical country like India. But it varies depending upon the weather conditions also. In the winter period, you find that the period may be extended. In the summer, particularly in the west, in the place like very hot place like Rajasthan, North India, even the 8 hours are the maybe late period. Then how the body is being kept in the house, that is another contributing factor. So it is a rough period, and in certain conditions where the body is kept in a cool environment, it can even be taken at the even up to 10 hours of the time. Next, please. What are supposed to be checked, do's and don'ts before harvesting cornea by the technicians, ophthalmologist, or the doctor? The first of all, the legal document has to be checked. The death certificate, very important. This has to be verified that some registered medical practitioner has endorsed the death. And if the doctor has gone for harvesting cornea and somebody says कि भाई हमारे पास certificate नहीं है, आप you do the certification, it should not be done. It has to be that independently the death has been certified, and there is a written and valid consent obtained from the next of kin. In certain cases, like the MLC is suspected MLC cases, downing, hanging, road traffic accidents, or any unusual occurrence, the police and administrative consent is very important. The government of India has issued a clear instruction to the respective state administrative authorities that the police clearance should be provided at the earliest in these cases, because in most of the autopsies, the eyeballs are not taken for the histopathological or any suspicious for the investigations purpose. So the eyes can be taken, and local police authorities, by and large, they are very cooperative to issue such consent in a reasonably good time. Earlier, it was a difficult task, but now since it has been notified by the government of India, the state authorities are taking due care of it. We have to inform them about this. If somebody is ignorant about it, then this is being conveyed, and by and large, it has been carried out. Second issue comes with the medical documents, because you have to root out the possibilities of viral infections like COVID, HIV, etc. So the blood has to be obtained for the essential tests like HIV, COVID-19, etc. from the deceased body. However, if there are the various patient was having disease for a longer period hospitalized, there will be certain documentations will be available. So if these are available, the medical documents, then the blood may not be required to take out. Then the humidity, temperature status, that the body decompensation, etc., has not taken place. The position of the head, that it should not be too low and too high. Basically, the pillow should not be kept below the head. They should be carried out. Next, please. So whether it is burn or bury, any religious sentiments, it is if it is not burnt or buried and donated, definitely this will provide at least for the life to the four blind people. Like the two eyes we are taken, the one eye is given for the optical purpose, the penetrating keratoplasty. In the second eye, we can have the anterior lamellar keratoplasty, DEL, or the posterior endothelial keratoplasty is DSEC and DMAC, and it becomes free. Then you have the limbal stem cells can be given to the multiple. So one donation can definitely go up to the 4 to 5 blind people are benefited. Next, please. This was the part A I had kept for the eye donation purpose. What are do's, don'ts, indications, contraindication, which is very useful for the practical purpose and the examination part of it. Now, part B, we are now going for the eye banking and the corneal transplant regulations activities in our country. It is always better to remember our forefathers, the historical background of any. This is a part of the learning in medicine, and to maintain the chain with this. Next, please. Now, the first human full thickness corneal transplant, where the human cadaveric cornea was used for the transplant purpose by a Austrian ophthalmologist, and it was carried out on 7th December 1905. Next, please. Older generation of ophthalmologists, they are very much acquainted with the name of Costrovijo, and on his contribution in 30s, actually there was so many surgeons were working on it in 1930s to 40. There was a period in the USA when this corneal transplant activities has taken a good shape, and Costrovijo's contribution in performing penetrating keratoplasty, he has designed innovated surgical instrument, and we still use the corneal seizure, which is named on the Costrovijo's corneal seizures. Next, please. Next, please. Let's come to the Indian scenario. The first corneal transplant, again, it is the human cadaveric harvested cornea. Otherwise, the allogenic corneal transplant were carried out earlier from the pig corneas, and those were grossly rejected because of the strong immunological reactions all over the world. The first Indian corneal transplant took place somewhere in 1948 in the Chennai, the government medical college and the hospital. Dr. R.E.S. Muthaiya, he established the first nation's eye bank in 1945. So the great contribution. Next, please. The first eye bank, formal eye bank, was founded by Dr. Townley Patton in 1944 in the New York City. The Eye Bank for Sight Restoration remains an active member of the Eye Bank Association of America, which was founded in 1961. And the Eye Bank Association of America is one of the world's oldest transplant association. Not only the eye corneal transplant, but other transplant activities also. And this is globally recognized for setting up the standards for the eye banks. We are the Indian Eye Bank Society, the Eye Bank Society of India, EBAI, is the member of Global Alliance of Eye Banks. Next, please. If we go quick, the eye banking journey in our country, in 1945, as I mentioned, the first eye bank setup. Eye Bank Association of India was founded in 1989. And these are the founder members, Dr. R.P. Dhada, Dr. Majumdar, Dr. G.N. Rao, the famous Dr. G.N. Rao, who has developed L.B. Prasad Eye Institute in Hyderabad, Jaswant Bhai Mehta and Dr. Anita Panda, the renowned corneal surgeon from the All India Institute of Delhi. They made a society, and here I would like to mention about Dr. R.P. Dhanda that he has rather after Dr. Muthaiya, he did the maximum contribution in propagating and the first corneal transplant of the Central India and North India was performed by him in 1954 or so. And he continued to be the living legend in the field of eye banking and corneal transplant. Next, please. The journey continues. 89 Eye Bank Association was formed. Then the program was basically linked with the voluntary eye donations. And obviously the quality of cornea achieved in our country with the too much variety and the temperatures, etc., and other socio-economic status, the corneal grafts were not very healthy. And so this the concept of hospital cornea retrieval program was conceived by Dr. G.N. Rao in Hyderabad. And in 1991, he implemented in his Ramayana Eye Bank of the L.B. Prasad Eye Institute. And subsequently, it was adopted all over the country. And now it has become the program which is governed by the Government of India. The Human Organ Transplant Act was enacted in 1994, but it has a certain issue. So far, it was considered for the eye donations and the cornea harvesting, because before 1994, we were able to harvest cornea by the help of the technicians. But after this Human Organ Transplant Act, the necessity was made at par with the harvesting kidney, part of liver and other organ. So that has given a very strong reverse direction to the eye banking and eye donation activities in our country. We represented it to the Government of India through various channels, including the EVI. And subsequently, we got the amendments in the THOA Act, and it has become now Organ and Tissue Act, where the cornea is considered as a tissue. Hence, now the trained technicians can harvest the cornea. After this act problem, the next problem came with the COVID. And as we all know that the COVID has changed our life pattern, right from the socio-economic problems, developing status, health problems, and some byproducts are good, like the Zoom meeting, the virtual meetings. This has come, all work from home, all this has come because of the COVID-19. It is saving a lot of time. But for the eye donation, where we were in the 2019, we were able to get almost 60,000 corneas and 35,000 corneal transplant. For the next 2 years, it was reduced drastically, and gradually it has started taking place jump. And now, after 6 years of the gap, we have achieved the same pattern and the number what was in the 2019. So there is a 6 year, we are now trailing behind our all targets. Next, please. This is the present scenario of eye banking in our country. There are more than 760 institutional members, eye banks and eye donation centers registered with the Eye Bank Association of India, which is the only professional society for the eye bankers in our country, and gives advice to the central government about recommendations for the how to improve the eye donation activities and other legislations modifications. About the collections, I have already mentioned. Unfortunately, not all eye banks are very effectively functioning. About 15 eye banks, means 2% of 760 organizations, accounts for more than 80% of total collection. And only 4% of the 760 organizations can be classified as full-fledged eye banks. So that is why. Yeah, next please, slide. Next slide. Yeah. So this is that is why now there is a plan to change this setup, and more non-functional or partly functioning eye banks should be switched over to the form of the eye donations or the cornea collection centers. Next, please. Collection versus utilization. That a good standard says that if you have 50 to 60% of the utilization is very good. It was for the optical purpose before the propagation of lamellar keratoplasties anterior and posterior. If you have better collection, better in the sense means the cornea transplant, before that the endothelial cell count is very good, transparency is good. In those circumstances, utilization will also increase. Then with the performance, other parameters like the more, now we are switching over to the partial keratoplasties like the DELC and the DSEC and DMEC. This will also improve the utilization. But by and large, we are still around 65 to 70% the maximum. We can consider that the collection versus utilization ratio. Next, please. This I have already mentioned that if we need to have the 1 lakh corneal transplant annually, should have 2 lakhs cornea collections. And considering that today we are around 60,000 cornea collections and 37,000. So it is far off from our target, but we have redefined our targets and hoping to achieve at least 1 lakh cornea collection from 60,000 to 1 lakh by 2030, and to the tune up to the 2 lakhs by 2035. That is our mid-course correction, considering all issues which we have encountered in last 1 decade. Next, please. Now this goes roughly estimate that if you have to go the 1 eye bank for 20 million population, should be able to provide adequate number of the cornea to cope up with the backlog, and every year adding 50,000 cases are also considered. Next, please. Zonal distribution, those who are interested that how it is performing, all you see that I have already mentioned about it. In the North India, there is a taboo of the myth and all those things. So North, Central and East zones, their contribution is less. The South zone has a maximum contribution, particularly because the earlier there is a more higher education status. Literacy rate is very high. That religious taboos are not figured. And over and above, the number of renowned institutions, ophthalmic, at least ophthalmic institutions in our country, the South, West and South zone carries the maximum number. That is another reason that continuously, even after post-COVID period, South zone and North zone, they are doing well compared to the previous figure, but other zones are also picking up in the number and ratio is changing. Next, please. Now we discuss about the eye bank. What does it mean? Eye bank is a community non-profit charitable organization which is dedicated to restoring sight to those who are blind or visually impaired through the promotion and advancement of eye donations. Here, this photograph I picked up from FMC Pune, where we were able to establish the limbal stem cell transplant unit. And the photograph is not placed because I was the part of it to start with. The gentleman in the white, Dr. S. Badrinath, the late Dr. S. Badrinath, founder of the famous Shankar Netralaya in Chennai. He is considered as the father of the modern ophthalmology, not only in the India, but in the entire Asia. So it is a my tribute to the man who has given tremendous boost and promotion propagation of not only the eye donation activities but the entire spectrum of the modernization of ophthalmology in our country. Next, please. So by and large, it is eye bank is a link between the donor family and a cornea recipient. We have to approach to the donor family, harvest the cornea, assess it, and proceed further. Next, please. These are the broad outline the functions of the eye bank. As mentioned, it's a link between the donor family and cornea recipient to procure quality tissue through voluntary donation or hospital cornea retrieval program. And to receive a quality tissue, we have to approach early, harvest early, process early, and distribute early. So it's a very important task, which is the eye banks are shouldering in our country. Screen eyes as per the eye bank standard, which is formulated by the government of India, depending upon different recommendations as per the prevailing situations in our country, as well as to match with the global standards. Now, to evaluate the tissue here, you need to have a specular microscope, eye bank specular microscope, to see the cell count, the transparency, and the structure of the corneal stroma. Test for the HIV hepatitis if these reports are not available. For that, the blood would have been obtained from the cadaver, and to eliminate the waiting list. These are the eye bank functions. Next, please. A standard eye bank is supposed to have the lamellar airflow to ensure that the cornea maintain its best of the quality. The specular microscope procedure, as I have mentioned. Next, please. Cornea processing lab does not require a very huge area. Even a room size of 12 by 15 feet is good enough for establishing the cornea processing lab. You need one trained technician, you need a good slit lamp, then specular microscope, lamellar flow, and for the data you should have a good server and computer, which is now in the part of our life. So you are maintaining the data registry or to whom to distribute the cornea, as well as to keep maintain the data of the cornea which you have already received, and use these data documented for the legal purpose or the government purpose. Next, please. The common preservative media which is used nowadays is cortisol, the intermediate media. Prior to that was the MK medium. So there is a one fridge is also required where it is kept, and in the center you have the system where the old system where you have the cold moist chamber. This was in our days when I started practicing ophthalmology way back in 1980s. We had only the cold moist chamber where you are taking out the ice, keeping in a bottle, glass bottle, where there is a little bit glycerin and the water is poured over which the cotton is kept. And that moist chamber was good to keep the cornea viable for the period of 8 to 10 hours. So those days it was the collect the cornea and immediately start transplanting. The whole night we used to operate, but now later on came the MK media. I'll discuss later on how these medias help us. Next, please. I mentioned the first 24 hours, that is the moist chamber. Then we have the MK media, which is viable for the period of 72 to 96 hours, depending upon the temperature and other conditions. Once we got the MK media, then it's the situation has improved. The quality of the graft material, which is transported up to the surgeon, was definitely better than what we were getting with the moist chamber, because the moist chamber was it was restricting the distribution of cornea only up to the local level. With the MK media, we were able to transport the cornea all over the country. And in the distribution of the cornea through MK media, the All India Institute Delhi RP Center of Ophthalmic Sciences helped to develop the MK media. LV Prasad initially, their Ramayana Eye Bank, they developed the MK media in our country, and the Eye Bank Association of India was the part of the distribution system. The next stage, which is the revolutionized corneal transplant activities, is the Optisol and the Cornisol preservative media. These are very effective for the period of 12 to 15 days. So now it's even from the remote area, the cornea can be obtained. So now all good eye banks, they are using Optisol or the Cornisol for preserving the cornea and for the distribution purpose. The cost wise, obviously, the moist chamber is the cheapest one. Then the MK media, the cost is highly subsidized by us, and we charge only for the transportation and other purpose, the preparation, not the full cost. So it costs to the eye banker at least around 600 rupees per cornea, whereas the Cornisol and Optisol, it may be costing around 12 to 1500 rupees. But it is definitely the quality of the material, what we are getting and transporting and using has improved substantially with this use. My request to all my PGs, those who are attending this webinar, that please read more about preservative media, not only for the purpose of this corneal transplant activity, but it is for the examination point of view. What is eye bank? Then the Human Organ Transplant Act, Act 1994 and 2011, and preservative media are very, very important topic for the OSCE as well as for the theory paper. So please take the lead from this presentation and read more on these aspects. Next, please. Voluntary donation was till this we have hospital cornea retrieval, because it has the limitations of the high rate of tissue discard, poor screening at the donation site, increased death to retrieval time, and voluntary donation can be expensive because so many resources are required. Whereas in the hospital cornea retrieval program, the patient is in the hospital under constant monitoring. There the grief counselors are available, laboratory facilities are available, harvesting, the counseling is easy to perform, early to perform, and then to use the cornea. So obviously, voluntary donation had a significant shortcomings, but that doesn't mean that we have already totally discarded voluntary donation. A major share of cornea from the rural areas by the help of so many NGOs and cornea collection centers are collected through the voluntary donation. But there is a shift towards the hospital retrieval cornea program. Next, please. I have already mentioned that how this SCRP is better than voluntary donation program. Next, please. It's more efficient, provides higher quality of donors than voluntary. Number is, that is both the quality as well as quantity. Both are increased with the SCRP, and large hospitals potential is effectively captured by the so many eye banks. So in metro cities, we find that the eye banks are getting program linked themselves with the large hospitals, whether they are irrespective government or the corporate hospitals. And with this coordination of the eye bank and the large hospitals, the number of donation is definitely increased in our country. Better medical screening, well-trained counselor, technicians are ready to get the cornea at the earliest opportunity, because they are in the same setup, sitting there, not in the voluntary that somebody has given you the call, then you start working on it, to whom to send it, and so the time period which is taken is also low. And gradually there is an increase in the utilization since we have started the SCRP in our country. Next, please. So now there is a paradigm shift in iBanking. There is a more emphasis on utilization rather than only the collection. The number of collection should not be compromised with the less number of utilization. It is something like the same way that earning 100 rupees and spending 101 rupees, or rather than you earn 10 rupees and spend only 1 and 9 is key for the other purpose. The same way, more corneas you have received, but utilization is less, then the purpose is defeated to great extent. So increase utilization by the improving the environment, development in our country, education, environmental factors. Earlier, even the fan was a luxury. Now, air conditioner has become a routine affair. So our country that changing in the lifestyle pattern, SCRP programs, all those are now reflecting in the better utilization. Use of the intermediate corneal storage solutions like Cortisol and Optisol, I have already highlighted. Charity model to self-sustainable model. Though it is called the Netradan Mahadan, but charity has to be, somebody has to pay for it. If the patient is not paying, if the system is not paying, but who will pay? So it's you have to develop an infrastructure. You need a eye bank specular microscope, which cost around 40 lakhs. You need a different other infrastructures, equipments, and then the staff, counselor, technicians. So to run a eye bank, which is not a very profitable organization, is a very difficult to sustain. So the charity model to the self-sustainable model gradually shifting. CSR support is there, government aid is there, but to become the self-sustainable, some kind of a levy has to be obtained. And for that, we are insisting to the government that the amount which is required for the, at least for the getting the test, laboratory test is carried out for the HIV, COVID and other requisite. It has to be there. We should be paid for it. And the processing charges in the iBank should also be reimbursed by the colleges, hospitals, surgeons. Now, earlier we were getting the full cornea, and whether it is required to be used as an optical purpose, the penetrating keratoplasty or the partial thickness. So that was having a hindrance to switch over to the need of endothelial transplant or the anterior lamellar keratoplasty, because of you need more technical expertise, you need more time and equipment. Like if you want to have the microkeratome to cut the to get the demat roll or the dissect tissue is cost, use cost is there, and that amount what you are going to install in that keratome will not be able to return it back at the different surgeon at the level of the surgeon. But if the eye bank has a one keratome which can cater for the eye bank is catering for the cornea to the various institutions. So the pre-cut tissue as that system has now developed. Good eye banks, they have the facilities to provide pre-cut tissue, and it has made quality of the pre-cut tissue is very good. It is the time which is used to prepare and then transplant, that has also curtailed down. So that has also resulted in the better outcome of the surgical procedure. Next, please. Policy, government policies has to, which is a revolving policy and culture and ethos. It will keep on changing. We all had a alarm clock time, table clock, then we had a telephone of different type. We had a television, transistors. Now things are, we have gone to the A drive in the computer, CD drive, DVD drive, everything has gone. Smart phones have now you have. So if I talk about the pager as a mandatory, will it be feasible now? So it has to be changed. There is a mandatory death. Gradually that notification of death has become regular affair by the law because of that so many claims are there, which is whether insurance claim, property, etc. So the death registration has started, but the mandatory death notification in the hospital to the nearest, it's where whatever the death has taken place, the registry, the death certificate is issued. Simultaneously, there has to be a legislation that the mandatory death notification to the nearest I-bank for the I-bank donation counseling should be carried out in the, because in our country the rules are very rigid on this concept. We have to approach. There is no government support on this. This legislation is very much required. Earlier, the next of kin was confined only to the uh, parents, brother, sister, and spouse. In certain circumstances, even the grandchildren and other relatives, they were even willing, but they were not able to do the eye donation activity. With the great difficulty, we could get it amended. So there will be keep on changing in the like the request law. Typically, mandate hospital utilize accepted medical standards in articulating policies for identification of potential organ donor. US and European countries, the getting the cornea is much easier because the government laws are very clear that any death has taken place. They don't go for the voluntary donation and getting the consent of the next of kin. If the hospital authorities feel that it is required, they give this issue the instructions and it has been taken. It is legislative, legally it is valid there. Next, please. Now, policy changes favoring the corneal donation. The first person consent is very important. The number of donors, if you increase that, is the first consent has to be taken by the who are the legally binding. So here I mentioned about the family consent. How can it be modified socially or with the legislations? Next, please. There should be legal access to the eye bankers, to the access to the trauma centers, mortuaries, and mandatory SCRP at large, medium, and mortality hospitals. It's not difficult. It's only the mindset. Like 10 years ago, rather 15 years ago, the NABH was considered as a big issue, and healthcare delivery system was not willing to accept it as a norm. But with the government legislations, more shifting of the government's attitude towards the insured healthcare by the insurance system, it has become a part of this thing. The all medical healthcare delivery stakeholders, they accept NABH as an important issue to take over. So the same way, the access to the trauma centers, mortuaries, and mandatory SCRP and large and medium mortality hospital. I think this is the high time that government must consider this, and it will definitely improve the waiting period to collect the harvest the cornea as well as other activities to utilize this cornea in very limited period which we have available to us from harvesting to the transplant. Next, please. It looks little tricky. The telephonic consent about the, you are worrying about the fraud calls and you are asking for the telephonic consent. When I had approached some senior bureaucrats in the ministry, it was their words. But then I had explained, sir, you are worrying about this, but now look at that our digital India system. Again, another byproduct of the COVID, post-COVID era or COVID era. Like I required my this thing, something with my HDFC bank account verification, the KYC, etc. For that is now being done, carried out on the video systems is available. Your Aadhaar card is now made on the this thing. Passports are also digitally prepared. So the telephonic consent, the video telephonic consent, I think it is the high time that we should consider as a part of our system. Next, please. I have already mentioned that charity, how big should be the charity? Charity means someone else is paying for the job which is I have done for the free of cost or highly subsidized. IBanks, as I mentioned, the cost reimbursement of all expenses is enormous, and thanks to our CSR system, thanks to the in our country, there are so many groups are there, families. I won't call it if I say the Gujarati families, they do the maximum donation and they donate maximum money. Marwadis, so probably somebody will say that I am inclined to get some favor from the present government, but it is a fact. The Gujarati communities and Marwadis, they share the maximum share of banking activities all over the country, and the maximum funds donation comes for this purpose is from them, and the government grant is highly insufficient to run an iBank. Central government pays 5,000 rupees for this thing collection of the eye, not for collection but for the transplant purpose. So it should be on the collection, and I must acknowledge the contribution of the Haryana government, the previous Haryana government led by CM Manohar Lal ji that time, that they have given an additional grant of 5,000 rupees to cover the cost coverage of the corneal donation, and that money was given to the IBank. So it is very important that policy changes in favoring corneal donation has to be customized, tailored as per the demand of the time of the day. Next, please. This is a very important issue, and again, I would acknowledge our Surface Transport Minister Nitin Gadkari ji, Honorable Nitin Gadkari ji, because they have agreed upon it, and it is now coming amendment in the of 2018. It's a step up, like you have the blood group available with your driving license, and in continuity that we should have for the potential donors, it should be definitely mentioned those who are the organ donor, the eye donor. It can be printed in Aadhaar card, in the all government documents. That will definitely help to improve it further. Next, please. In the same manner, like for the school curriculum, we cannot go with the school and college curriculum of 1940s pre-independence era. With the time changes, like we have to see about the various organ transplant activities, donor activities. The children should be educated about the disaster management. That is another is coming, pollution, environment protections. So these are the syllabus has to be this thing. And Rajasthan government has taken lead about the organ donation chapters are included in the middle school curriculum. About certain changes in the cornea donation, I have most of the points I have already discussed, and now issue comes with the certain states, because fortunately or unfortunately the health is a subject which is in the concurrent list, but mainly the health is a state subject. So because of that, certain states like the Maharashtra, they don't allow transportation of cornea from Maharashtra to other states, irrespective whether it is surplus available there. Now, this is definitely restricts our activities of not only harvesting cornea, but transportation of cornea and other organs too. So this change policy has to be changed, and they say you first the total list of that state has to be cleared, which is very impossible. The state is not a one pinpoint area where you have the is a large state like the Maharashtra, Rajasthan, or in the Uttarakhand, in the remote areas, if one person is waiting for corneal transplant in remote area and he is not willing because of some harvesting season or some marriage, etc. in the family, you cannot stand still. Most of the states, they have modified it, and central registry system, here the NOTO is taking actions. iBank Association of India, we are maintaining our activities. So gradually there is a synergy is being developed on in the activities of EVI, NOTO and NPCB, but it needs more strengthening and more coordination. Next, please. Training centers are very important. That this is not only the training of technicians, training of the counselors, training of the managers, and training of the ophthalmic surgeons, those who are engaged with the corneal transplant. Number of functional eye banks, we should make it from 30 to the 45 with the different locations of the cornea, and the less functioning eye banks and the eye collection center, the number from 700 to should increase to the 2000 collection centers. By this, we'll be able to cope up with the activities of the eye banking requirement, eradication of blindness in our country. And as our Honorable Prime Minister insists that the India should take lead, as we say that the entire globe is the family. So our other social, not I would say compulsion, but the responsibility in the underdeveloped South globe. South part is our government's issue, that the South of Southern America and African countries, we should be able to help them in technical advancement in their activities as well as providing cornea. Look at the small country like Sri Lanka. Sri Lanka is one of the largest exporter of the cornea all over the world after the US. It is all the government initiative and the social norms in such a small country, which happens to be the part of the same India subcontinent now, the grand India 100 years ago. So nothing is impossible. Next, please. So what is next is that we should have the proper accreditation of the standalone eye banks by the NABA. NABA is giving this thing accreditation to the blood banks, different labs, and in the eye bank as a part of the ophthalmic department of a hospital. But there, as I mentioned, that at least we have 60% eye banks, those who are not directly linked with any hospital, they are standalone. And they should also be considered. We are, as a EBI, we are working on it to have a proper accreditation with the NABA to regularize this and improve the quality of training, quality of functioning, and utilization. Every right now, nodal training center used to be All India Institute or Delhi, where the Rajendra Prasad Ophthalmic Center is considered as the training center for the government organizations. Then short courses were carried out. In the corporate setup, so many hospitals in the south, they have developed their own training centers, but it is not officially accredited or recognized. So these training centers should be recognized by the government, and it is proposed that each of the 5 zones and subsequently every state would have a eye bank training center. That includes the training of all the stakeholders of the eye banking. Next, please. Any training is highly insufficient if the trainer and trainees, they are not highly motivated, and the training capsule is very, the quality wise, it has to be at par with any global standards. Availability of skilled cornea specialists is a very crucial rate limited link to eradicate avoidable corneal blindness in our country. The corneal transplant is not a very profitable work. It does not give you more money. It takes a lot of time to operate. and the follow-up is very long. And that is the reason that the skilled cornea specialist number is very less in our country. Those who have been trained in the cornea, they prefer to go for the cataract and the refractive surgery. So that is why we have to promote corneal training of the special ophthalmologist in the corneal transplant. And if number is, if we have 1,000 well-trained certified specialists and working regularly, then it is not difficult to get the target of 1 lakh transplants annually. Most of our seniors, they stop operating, either they are in the administration of the government setup or in the corporate setup. Very few they continue, and I am very happy to continue even in the late 60s to continue do the corneal transplant, because it is our commitment to the country and commitment to the society. My earnest request to each and every ophthalmologist, irrespective whether he is a retina surgeon or corneal surgeon, must take this as important the training, either himself train or at least develop an environment to train technicians, counselors, and other stakeholders of the eye banking. Next, please. Next, please. Next, please. Yeah. So now it is time that we should have a more standalone eye banks, independent standalone, should primarily meet the need of the region with a robust mechanism for unbiased distribution of the collected corneas to common waiting list of potential recipients. I give you the example of standalone eye banks too. One is the Rajasthan Eye Bank in the Jaipur. They are doing extremely good job and providing cornea to the larger part of the Rajasthan and then the southern Haryana and even to the Gujarat. The eye bank in Indore, the MK International, they are doing excellent work. They can catch more than 1,000 corneas per year and distributing. Like that, the standalone eye banks not linked with the eye hospitals or big hospitals, they do better because they are unbiased and they are of the good work and great asset to the society. Next, please. Distribution. The distribution, there are the certain measures which should be considered. A transparent and interactive online portal, unique identification number for every patient, and national corneal transplant registry. We are away from these three objectives, but I am very hopeful that within 5 years, we should be able to achieve at least 2 of these. Next, please. I am just on the verge of concluding this lecture. This is on the card. In the US, it has started coming commercial way, the biomedical engineering of the cornea. But till now, we are not able to develop the endothelium. And the viable endothelium is very important. They act as a basically support to the stroma, but they are not, as on today, they are not going to replace the corneal transplant activities. It is just a one addition to it, but yes, the future is open. It may come after a decade or so. Next, please. This eye donation fortnight, few words about it. It was started in 1986 by the government of India to propagate and promote the eye banking activities, corneal donation in our country. And it is aimed to combat all the corneal blindness which affects millions of people in India. It serves multiple purposes, including raising awareness and dispelling myth. We all take part, and I must acknowledge and thanks Doordarshan for during this fortnight they give their programs, prepare it, and I've been part of these activities since 2006 to this almost 20 years. These people are Total Health Program is contributing, TD National is contributing, and certain other private channels, they also take it. So once you develop the awareness, obviously the society grows in it and our aim is achieved. Next, please. This was for the 25, what was the one donor can help restore sight to the two needy individuals. Next, please. The World Sight Day is the international activity. It is observed annually on the second Thursday of the October. It's a global event meant to draw attention to blindness and vision impairment, not only the cornea, but all kind of blindness. Initiated by the Sight First campaign of the Lions Club of International Foundation in 2000, and now it is being accepted by WHO as a global responsibility, and it is integrated with the International Agency for the Prevention of Blindness in cooperation with the WHO. This World Sight Day and Eye Donation Fortnight is good for the awareness campaign, but it is equally good for the PGs to know about it, to participate, as well as they may be asked during OSCE about these dates or the aim and objectives of these two functions. Next, please. To conclude, mandatory notification to eye banks for all hospital deaths from short-term media to intermediate or long-term media changes, focus on the financial sustainability of the eye bank, building a network for wider distribution of cornea, uses of technology for better data tracking, and to develop a robust patient discovery program. Next, please. Indian eye banking have come a long way in last decade or so. Our focus areas are moving for voluntary base to SCRP, development of training centers, train the trainer program for all cadre of the eye bank, implementation of required request law, and first person consent. Consent. These are our immediate targets. Next, please. To conclude, मानव जीवन बहुमूल्य जैसा है हरित वन नेत्रदान अनमोल जैसा है जीवन जल. It means that you protect environment and go for the eye donation. These two are very crucial. And Harit Vardi means the olive uniform which I worn for 35 years. I believe that पुनः जन्म हो मेरा तो हो भारत धरती पर पहनू हरित वर्दी हर जन भारत माँ तुझे शत शत प्रणाम. जय हिंद. I am thankful to National Academy of Medical Sciences for giving me this opportunity to discuss with you on as a myself as a ophthalmologist and as a president of Eye Bank Association of India. Thank you very much.
Thank you, sir. Am I audible now?
Yes.
Thank you so much, sir, for an enlightening and informative session. And I must say the last slide was really lovely. This session was not only a recapitulation for the audience, but also I could revise and update my information on eye donation. So thank you so much. We
Thank
have
you.
a few mixed bag of questions from the curious minds here. One of which is, can one patient who has undergone LASIK donate his or her cornea? Will it be helpful for the endothelial component, sir?
Yeah, I've already mentioned it. In fact, we need now it is not only the optical keratoplasty, the penetrating keratoplasty. So in the LASIK, you are not going to touch stroma or the endothelium. You are going only with even in the silk lenticule, which is less than 100 micron or so. So the DMAC, DSEC, yes, it is used. There is no bar on it.
Thank you, sir. Another question that addresses the ground level lacuna. It is from a state level resident who is working where the HCRP doesn't have enough counselors. So how to increase or improve the willingness in the next of kin for corneal donation?
Frankly speaking, in SCRP, when we started, even in armed forces, in the hospitals, we didn't had a counselors. We all, and before that in medical colleges in 80s or so, the residents themselves used to be the counselor. And I am still counselor. I don't mind to do it. It is your mindset. It is not available that I will not do it. It's not correct. We should start doing it and then ask for it. In the government setup also now it is MCI has asked the mandatory to have a this thing counselor psychiatrist for running the MD courses in the medicine and psychiatry and all. And like that we have used them. When we started post-graduation in under when Professor Sood was with the national board, we started with these activities and we have utilized them. And in Pune, in FMC, we were making the eye donation drive outside the college itself. And you won't believe that I have utilized the services of Lions volunteers, all those big Sethanis and multi-millionaire people. We took them for these jobs and said, "We have to doctor se bhi badke ho. You are very soft spoken, knowledgeable. Why don't you take it?" And I have been going regularly to address Akhil Bharati Marwari Sammelan. Yesterday only their new president Dr. Rajkumari Jain took almost half an hour talk with me. He said, "सर आप मौका दीजिए, हम तो सब कुछ करने को तैयार हैं, हर किसी पे जाके काउंसिल करेंगे, पुलिस वालों को भी करेंगे, कलेक्टर को भी करेंगे, पेशेंट को भी करेंगे." So it is a basically mindset.
Thank you, sir. You're indeed an example for the young ophthalmologists. There is one question from Dr. Jaswant. If one with radial keratotomy, that patient can donate eyes or not? This has been addressed, however.
Actually, radial keratotomy is an obsolete procedure now. Yes, number of deaths now coming the radial keratotomy induced, which was done in the 80s. But corneal scarred corneas, I don't think it is useful for corneal transplant, but their limbal lenticules can be used for the purpose. So we never, even for the HIV patient or COVID, we don't deny eye donation. We accept them, but it is not used for the corneal transplant purpose. And now since we have the limbal stem cell lenticules in ocular surface burn cases, Steven Johnson, etc., so their limbal tissue can be used. But definitely optical purpose, DSAC or DMAC, these corneas cannot be used.
Right, sir. Last question, sir. The concomitant use of glycerine in extending the shelf life of donor tissue. How helpful is it, sir?
See, this is one of the component of preservative media is okay. But now this moist chamber it is not used so often now. It is just as if you don't have nothing. And the cortisol is the best one as on today. So you have a ready-made customized cortisol or optisol. These are used and days are not far off, then you will have a long-term cornea preservative. In between the cryopreservation also came, but it's not handy transportable. So better we don't change with the preservative media, let it come through the reliable standard sources and we use it.
Thank you, sir. Your answers were really helpful, sir. The chat box is open to the floor if there are any questions in the house. The audience is lucky to have such an eminent speaker on this topic.
Thank you, ma'am. You are so generous.
So we do not have any questions, sir. So I would like to welcome Dr. A.K. Sood, sir, to present the vote of thanks.
Thank you, Dr. Singh. On the behalf of the National Academy of Medical Sciences, indeed it is my great privilege and pleasure to thank the distinguished speaker, Major General J.K.S. Pariyar, sir. Sir has been our senior fellow and very, very supportive to the Academy. I must say that this series on ophthalmology, sir was the chief coordinator and he selected the best speaker and the best topic. So thank you so much, sir, for your valuable support to the Academy. And we look forward for a blessing in future also. So for the PG
students. Thank you, sir, for giving these great words and it inspired me to work more hard and come up to your expectations in future.
Thank you, sir. It is, I think, your great support to the Academy. For the student, I would like to say that in this series on ophthalmology, we have covered 5 very important topics. And all, I must say that the very eminent speakers from all over the country, which were selected by Major General Pariyar, sir, we have, and these recordings are available on the website of the National Academy. We have covered during this series, starting from the strabismus, management of squint or strabismus. Then we covered the diabetic retinopathy, then surgical management of glaucoma, and then how to handle pediatric stroma. And today we had a very interesting session by Pariyar sir itself. So thank you, sir, for all the support. I also
Thank you.
take this opportunity to thank all the faculty members from various institutions who have been supporting this program. Once again, I want to make an appeal that it is your own program. Please come forward to suggest the topic, and you can also suggest and come as a resource person in this program. So it is your own program. You can suggest the topic as well as you can come forward to take the session. For the PG student, again, I think the practical tips which sir has given today will be great importance. And the last point which he mentioned, that the attitude is very important. So please remember, you are the young ophthalmologist. And this, I think, is a great contribution to the country if you can motivate. First, you learn yourself and then motivate for eye donation organization. Another information for PG student is that we have, in collaboration with Indian Council of Medical Research, biostatistical helpline. So those PG students who want to have some help for their thesis, we have the eminent experts from the ICMR as well as our distinguished fellows who are supporting this. It is free of cost. Just you have to log in and you can book your site and time, and the eminent experts will be happy to help you. So far, more than 250 students have taken the benefit of this biostatistical helpline. For those PG students who are computer savvy and want to know about artificial intelligence, nowadays everybody is looking for the training and at least orientation training on artificial intelligence. The National Academy of Medical Sciences, in collaboration with Triple IIT Hyderabad, has started a 12-week online program on artificial intelligence in medical practice. And we have already completed two batches. One first batch, we had nearly 150 students. In second batch, again, 130 students. And the registration for the third batch is currently open. And if you are interested and computer savvy and IT savvy, you can register online. The details are available on NAMS website as well as the Triple IIT website at Hyderabad. For our NAMS family member, I would like to mention that our 65th convocation is planned at PGI Chandigarh from 7th to 9th November. The 7th, we have a CME program for the PG student, and the theme is critical care, which is very, very important nowadays. So those PG students, at least from Chandigarh, maybe Haryana, Himachal, they must at least. And the third day also, we have a CME program on sleep disorder. The main convocation will be held on the 8th of November. So NAMS fellow, I request them. We have already shared the brochure and details. So please grace this occasion. And once again, I would like to thank, today we have Dr. Ritu Singh, who had kindly agreed to moderate this session. So this was her first visit, but I will request her to be with us more frequently, and your contribution will be really appreciated. Here in our IT team, we had Mr. Ravi, who has been helping us in organizing this program on Zoom as well as on the YouTube. And all these recordings are available on the NAMS website. So far, we had more than 78 video sessions, and all these recordings are available on the NAMS website. So you can always download and go through that. Most eminent speakers we have all over the country who have contributed that. Mr. Shivam, again, who has been helping us from here. So once again, I'd like to thank all the participants, our faculty members, and special thanks to Major General Pariyar sir for helping us in organizing this series on ophthalmology. The next program is on thank you, sir. The next program is on 17th of October, where again we are going to have a very interesting session on headache. All of us know that headache is important, but there are certain conditions where headache could be a serious symptom. And again, we have expert from PGI Chandigarh, and Dr. Astha Kakkad is going to take that session. So those students who are interested, you can always send your questions. We can share your question with our expert and they will be happy to answer. So once again, thank you all for making this session very, very interactive. Over to you, Dr. Singh.
Thank you so much, sir. And we come to an end of today's meaningful session. I thank the Navigate platform, which is the brainchild of NAMS. I thank the faculty members and definitely our eminent speaker, Dr. Major General J.K.S. Pariyar, sir. Also, the wonderful audience for their time, engagement, and commitment. And as Sir said, we do have a lacuna, but the silver lining of the cloud is this nation observed 40th National Eye Donation Fortnight. Plus, we also have upcoming World Sight Day. So let us all stay informed. And until next time, keep learning. Jai Hind.
Thank you.